welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And, when you guys are listening to this, it is literally fresh off the heels of the Academy of Osseointegration meeting. So we know that you have just gotten to see some things that have changed the way you think about things. We know we have been challenged. So we're just excited to kind of be able to bring all of the recap of that coming up soon, coming up shortly. But, Wes, when you come off meetings like that, this time of year, there's a lot of education going on. You just kind of get excited about what's possible. And I think that's kind of what the show's going to be about today. But, Wes, what's been going on in your world these days?
Well, John, Laura and I have really gotten back into camping. And have you ever heard of a discada, John?
What did you say?
I just said it. The discada, right?
I have no idea. I've never heard that word.
So imagine going into the desert of Mexico, or maybe even into the United States, New Mexico, and there's these things that they made out of plow disc. Okay. And then basically they turned a plow disc into a cooking surface.
Oh.
Okay. So now how does this pair up with camping? So imagine a 24-inch seasoned, carbon steel disc of pure metal with some handles welded on it. And that you can use this, right? It's kind of like a shallow walk. Okay. So we're talking about like cooking over a fire with this thing, right? We're talking about making flatbread on it. We're talking about making, we took it camping with us. And my youngest daughter ordered up some special meals. We've made chicken teriyaki.
Okay.
Right? We've made filet mignon and asparagus on this thing.
So you basically just pack this thing up like a,
that's right,
kind of like a big disc, and you just pull this thing out, throw it over a legit fire after it's gotten to the point you want it, heat it up, and you have like a black stone, except this is made from an actual plow disc. Could
buy them from an actual plow disc. But this is actually designed. They sell them now in the commercial world as a discada that's actually purpose built. Yeah, it's pretty interesting. Yeah, you should check it out because it's super cool, right? It's fun to cook over a fire. John, you know this. I've been camping for a long time.
Oh, yeah. I'm all about
camping. And John, you like to hike. You like to do the stuff out in the woods, whatever that stuff is, right?
Yeah. Well, it's like my love language, man. Like if you want to go, my idea of a vacation, I like lots of things to go, see things, do things, whatever. But sitting around for a long period of time, I'm not good at. No. So if I can get outside in the woods or whatever, and we can also eat good food. See, that's the thing. When I go hiking, backpacking, whatever, usually my cooking involves boiling water and pouring it on top of something that becomes some type of food. Now, there's varying
purpose, but
there's varying degrees of goodness to that. So it depends on what brand you buy and how hungry you are. Everything tastes better in the woods. But if you could actually have, the outside plus good food, that's the perfect.
Well, that's
the perfect
been the
situation.
goal, right? We really wanted to kind of just, we're going to do some cool camping, but we're going to bring some cool food with us, right?
You're civilizing the experience.
It's not really, what do they call it? Glamping? It's not that.
But if the food's good, the rest almost doesn't matter to me, because you're having the experience of the outside. But rarely is honestly, when we go, you just usually, because I'm roughing it more in terms of like backpacking, whatever, you can't, but I miss that. Having a great meal under the stars, there's just nothing quite like it.
There's nothing quite like it. It's honestly amazing. We're
Discada.
Camping,
okay.
Right? Hey,
I'm
the
looking
Discada,
it up.
You got to check it up. Check it out. It's something that's super cool. Hey, John, if you're listening to this and we are fresh off the AO, don't forget, hey, text us, right? We got some great text. Recently, one of our favorite clinicians, Jeff Roush, listened to the episode. And if you haven't listened to this episode, I broke my wife's nose, right? The story of how John broke his wife's nose, intentionally, of course. And Jeff, we appreciate Jeff reaching out to us from Spear Education. He listened to the episode, sent us a text the other night. Super cool. I'm hearing from other people, and I'm pumped that you guys are starting to text us. So, hey, text the dental guys, 865-544-8954, and maybe even be the first to hear about new releases via text. How about that, John?
That's right. It's right. It's a way to get directly to us, which, historically we've not always been the best at, messaging people back because there's so much sometimes flying at us, but that might get you through. So before we get into today's show, I want to just thank our sponsor, the Dental Crafters Network. One of the sponsors has been with us for the long run. They have been with us through thick and thin. They have also not only been a great sponsor and a great relationship we've had, but the feedback we get from the listeners who try them out has just been amazing. And built on a foundation of unwavering dedication and respect, the Dental Crafters Network is a family-owned dental laboratory with 30-plus years of history, enriching the customer experience through their core values, responsiveness, versatility, and trust. They collaborate with you to meet your patient's unique needs. Experience the difference and receive 10% off your first case when you tell them the dental guy sent you. Call the Dental Crafters Network today at 1-800-472-8302. That's 1-800-472-8302, or visit dentalcrafters.net. And
love me some DG Network goodness. Yes.
Yeah, I mean, this is where we feel like we've had these types of relationships with the people that we actually we believe in what they're doing, and we see it every day in our practices. And what's really, really cool is we get to sometimes get access to not just technicians who are involved with this group, but the people who are writing the books, if you will, on what's going on in their specific area of lab tech, but also possibly in kind of what labs are doing across the country, across the globe. So we're excited, Wes, to have not only Brad, the dental lab guy, back with us today, but also Derek, the dental lab guy. And I want you guys to, before we because it's been a while, Brad, we've been looking forward to this for quite some time.
It's been too long, Brad.
It's been too long. So Brad, welcome back to the show, and introduce this dude. Who is this guy? Similar stash, we notice. So
that's true.
It's a brand. It's a brand. Yeah, there's a brand going on. So explain the brand and tell us about who's sitting to your right.
Well, I tell you, a proud dad moment, but after being in the dental lab for 34 years and having your son, Derek, sitting to my right, he went to mechanical engineering school up in Michigan, up in the upper UP, and he did 2 internships at Dental Crafters. And after he graduated, he looked at me and says, Dad, I kind of want to join the family business. And we all know dental lab is not what it used to be. In the old analog world, everything went digital, 3D printing, 5-axis milling. And ironically, mechanical engineering is a pretty huge asset for a dental laboratory. So super excited to have my son join us at Dental Crafters. And so Derek, welcome to the Dental Guys.
That was quite the intro. I feel very, very invited.
Welcome to the Dental Guys, Derek Sleminski. Let's go.
Yeah, the dental engineer guy, dental lab. It's still dental lab guy,
whoa.
But you never know.
Did he just claim a title, John?
I think we might.
Guy?
How many engineers have you interviewed?
That's true. We haven't
been able
anything
to
close. Yeah, I mean, now that I think is one. I think we'll let that pass. I think we kind of need to let that pass because. I mean, the chances of us having another mechanical engineer on the show are somewhat slim, but someone who actually understands, the world, a world we know very little about, which is the engineering world, although we have some crossover, but having the knowledge of what we do day in, day out in the dental world, but also this whole other world of mechanical engineering, we can only imagine what that does for a dental laboratory. And I I don't even know how many other dental laboratories in the country, in the world, have mechanical engineers on their staff. I mean, is this a common thing, guys?
Yeah, not that I know of. And again, no, maybe other labs do, but we actually have two mechanical engineers at the laboratory.
Two?
And two. We have
Wow.
Darren and Derek, both at the lab, and just helping us through the digital work process, making sure we're maximizing our milling strategies. We design our own milling strategies, maximizing on our 3D printers, all the digital workflow. I mean, that's all mechanical engineering. Industrial engineering, both of them have a little caveat of industrial engineering, which is efficiencies of workflow process. Because in essence, we're manufacturing, guys. We're just manufacturing teeth.
So
we're just doing
yeah.
that.
Just
teeth. We didn't bring Brad, the dental lab guy, back on the show to talk about just
teeth.
Right. Like, listen, if you guys are a longtime listener of the dental guys, you know Brad, the dental lab guy. You know he brings high level stuff, and today is no different. It is incredible what's going on in the lab industry. Brad, we had a recent episode where we did a little bit of scanner talk. John and I were really going back and forth of what scanner should we buy? Why should we buy this scanner? Why should we be? What's even possible with scanning today? Before COVID, we said, Brad, that adoption had kind of hovered below 20% across the board. And then for some reason, we don't understand, maybe you could shed some light on this tonight, is what has happened? Because from what we're hearing, adoption of digital scanning, intraoral scanning in particular, has increased surmountably. What have you seen, and what's your thought process on why this has happened?
We're at 65% saturation right now. So 65% of our customers are now digital and in climbing. Be honest with you, we even took a different stance at it. We really want to push digital. And we'd love to have 100% saturation. I know that's not possible. We're going to shoot for it. But to help us get there, we actually brought on our own scanner that we sell, service, support, because we think as a lab, we tend to get all the problems from the doctors anyways when it comes to, hey, my scanner is not doing this. I want to do this type of a procedure. What do I do? So we actually just started distributing the Shining scanner to push more of our doctors to go digital.
We see more of this, John. Labs really selling scanners.
Yep.
Labs providing scanners. I've even seen in the past labs giving away scanners just to get doctors to go digital. What's some of the problems you're seeing with that, Brad, or what's some of the good things you're seeing? Maybe problems? I mean, I know you've had a rant in the past about this, and I think it's time for you to rant a little bit about what you're seeing and what problems you're seeing and maybe what good you're seeing.
Isn't digital the answer to all of our problems?
I mean, hold on just a minute. I got my screens messed up here because this is a showstopper for just a second. I mean, what did you just say, John?
Yeah, I said, isn't digital the answer to all of our problems? Doesn't it solve everything?
I don't really think, Derek, does it solve all our problems?
If it's done right, absolutely.
If it's done right.
But it is very easy to mess up.
Just like if you take an impression right, we can make perfect things.
For everything.
Right?
Yep. If you do it right, no problems. You don't do it right, it's not going to save you. Never will.
It still comes to garbage in, garbage out. It still did. It's just now it's digital in, versus analog in. And it still comes back to the doctors have to really pay a really close attention. And the cool part is the tool gives them that ability to do it. They're able to look at the scan. They can zoom the scan in. They can see the data. They can see the clarity of what they do or don't have, how much clearance they have. They can look at all that before they send it. But they got to stop and make sure they take that opportunity before they click send. And unfortunately, with the labor issues that we have and things going on, a lot of the doctors are letting all of their team members do most of the scanning, which is great. And don't get me wrong, a lot of the assistants are better than the doctors are, but they got to be trained properly to make sure they're sending the right stuff to the laboratory.
So, Brad, when you say 65% of your work is digital, most of the work you're doing is single unit crown and bridge.
Not necessarily.
Okay. So of
No.
what's coming in, let's talk a little bit about what's coming in digital, right? Because you're not just a typical, Brad, the dental lab guy is not just sitting here making teeth. We're doing other stuff. So
Absolutely.
what's coming in that's digital, and kind of qualify that for me? Like, of the 65%, what's the breadth of what's coming in right now?
You named the first one, right?
Mm-hmm.
Crown and bridge, and not just singles, but we're doing, veneer cases, full mouth rehabs. If they can moisture control it and scan it, it's good data.
Mm.
The other things that are coming in: surgical guides, occlusal guards, partial frameworks, dentures.
Mm.
And we got to talk a little bit about that, because everybody claims dentures. It depends on how well you want your denture to fit. So there's a little caveat there. Tissue moves. A digital camera just takes an image of it at its present state. So you got to be careful with dentures. But we're getting preliminary, what can maybe call it, preliminary dentures there?
Yeah, pretty much.
Pre-op scans.
Mm-hmm.
So in majority, and it's amazing that most dentists are pushing this now. We never used to see that. It was like the lab pushing them. Now doctors are pushing us. We're getting the scans saying, hey, can you do this? Can you do this? I mean, they want to make digital scanning everything and get rid of impression material 100%. So we're being pushed by doctors, aren't we, Derek?
Yeah, every day. It's usually like testing out this, test out that, and it worked once. Let's try it again. Well, this worked again. Let's try it again. And all of a sudden, it's becoming a standard. It's becoming a process, and now everybody's trying to push it this way and that way.
Yep. Well, so if you talk about that, what are some of the things, and I think we could have a whole episode on this, and I want to be able to dive into a little bit of what you're doing with 2-dimensional versus 3-dimensional, but what are some of the things that you're seeing as some of the problems? Because obviously, as you said, if things are done well, then it's not a problem.
Mm-hmm.
But, with impressioning, I think we were all taught, including today's brand new dentist even, on what a poor impression is and kind of some of the pitfalls of it, regardless of whether it's being done well. We kind of know what some of the things are that are the main, issues with the laboratory. But what are you seeing with digital scanning as, the major maybe issues or problems that you're having to spend the most time on with the doctors?
Nothing changed from our last interview. Impressioning, the same problem we had with impressioning as we have with digital is retraction, cord retraction, getting the tissue out of the way, moisture infusion into the scan. We have to make sure we moisture control. It's almost worse than impressions, because at least impressions had the hydraulic pressure of the material to push things out of the way that worked to your advantage. This is a camera, so that hasn't changed. But Derek, what are we noticing as one of our highest remakes when it comes to capturing bite registrations with digital? That's been kind of our newest thing.
Yeah, absolutely. So usually when you're taking your traditional bite, the patient can't ever close more than what their teeth allow them to close. It stops. Always at that blue bite stop. But with a digital scanner, it has no idea. So if you're taking a digital bite scan and you go to the opposite side and you take another digital bite on that side, the software is having to kind of figure out where that tooth is, and it will have no problem completely violating that, upwards of 2 to 3 millimeters. So it might look good on one side, but your opposite side of your arch can be completely punching through the teeth. You'll never end up with that on a traditional bite if it's taken correctly, but digital, it doesn't care. So if you don't look for it, you're going to end up with that problem. If you look for it, no problem.
This is literally a company that we saw that's developed. It's an algorithm company where you can take all your bite scans, and they're promoting it to labs or dentists. You throw it up into their cloud, and they developed an algorithm to basically, touch teeth. So it's supposed to automatically through AI adjust every bite registration to touch. So if we get a bite that teeth aren't touching, or they're over touching, they're almost superimposed into each other, this company would run it through an algorithm and supposedly fix it through AI. I'll tell you that it's not 100% like everything. It can work in certain situations, but there's certain people they have an open anterior bite, and you don't want to, it is what it is, but an AI doesn't know that. So, but to tell you how big the problem is, the moral of the story is that a whole nother company developed to just try to fix the problem of improper bite registrations digitally. So that's been one of the problems.
Let me just ask you a question about that, because what scanners are having trouble with this, because to me, this is chair side. I get to see what the scanner I'm using is registering, and I get to verify it. And then, John, I know the scanner you're using allows you to verify. And Brad, you and I have been scanning since 2009. And you and I have had nothing but just great things to say about bite capture with scanning, which, if you go to any lecture right now on digital scanning and just single unit restorations, capturing bite is one of the greatest things you can do with a scanner, because it's just,
Absolutely.
it's incredible. So what you all talking about taking AI and putting it in with people's bites? Well, mine's already doing the bite. It's registering the models. It's capturing the jaw relationship record. What's going on your end? Like, where are we seeing the issues with? Is it with discount scanners? Is it poor software design? What's the problem here? Because this is the first time hearing of this. Johnny, you heard this?
Yeah, I'll let them answer the question. I can tell you a couple things that I've seen talking to a couple other people that are developing some different scanning stuff. But yeah, I want to hear what Brad and Derek have to say about that.
I'm not sure that we have enough data right now we're looking at and kind of calculating the data from different scanners to see if we can hone it in to see if it's scanner specific right now. So I don't think we have or prepared to talk about the data, but I pretty well tell you we're seeing it kind of across the board. You know, when we import a scan from the different scanners and throw it into primary two softwares the labs are using is a 3Shape or exocad. And when we throw it into the model builder is what we initially go, you know, we're seeing sometimes no touch at all and sometimes just super light touches, you know, where we can just barely see occlusal contact. So then there's tools within our softwares that we can, you know, click and move. And even 3Shape has an AI built in now. It's like we call it the auto button. I try to tell our techs to stay away from it, to be honest, because I don't think works very well at all. But you can hit auto, and it does algorithms too, where it kind of automatically adjusts occlusion and tries to mesh it together. So I'd say right now, to answer your question, we're seeing it kind of across the board with all the scanners. Wouldn't you agree, Derek?
Yeah, I think so. And just doing preliminary research of like scanning processes for many of the higher end like systems out there. I don't know if it's similar for budget type scanning systems, but almost every single one has that verification, like you said, Wes. You can see it. You can look for it. You can see if you took that bite, right? It'll show you what the bite looks like if you're looking for it. So I think a lot of this is coming through as I took the scan, we got the bites good, send it, go. Send it off the lab, let's roll into the next op, let's scan the next patient. It's for those people who are checking it out and actually looking at the step, because it's offering you the tool. Did you take this right? Did the patient open halfway through? Did they kind of wiggle their teeth side to side so that it might not be properly captured for that bite? But if you're not looking for it, it's not going to be captured right.
Yeah. When I saw, so interestingly to talk about this, and it's kind of funny we're going down this road because I was just geeking out on Journal of Prosthetic Dentistry this last week, and there's an interesting article there talking about validation of scan paths for comparing different scan paths for scanning of implant scan bodies. And they're talking about the different scan paths and what difference does it make to go, you know, back and forth on the scan. We can maybe post this at some point in the show notes versus just, you know, going longitudinally around the mouth and kind of coming back. And they talk about there's a tremendous difference, for instance, between if you just go, you know, like occlusal, then lingual, then buccal versus coming back and doing a buccal to lingual, buccal to lingual, buccal to lingual at the very end. And I had no idea, but they were showing the difference in accuracy because of the stitching and the way the stitching works with all of these different images we're taking. But when they talked about the bite, they said, you know, that just because we're taking this bite on, you know, think of the limited amount of data that we're really getting. If we just do, say, 3 to 4 tooth area on one side, we don't always do a second occlusal registration on the contralateral side. And many times, if you just scan quickly on, you know, say the right side during a single crown, and it does register, of course, it's always going to register, right? Like if the teeth are touching, the scanner goes, bam, got it, right? And when you look at it at a quick glance, and I've been guilty of this, you're like, got it. It lights up green or does whatever the scanner does to show you that you got it. But I have been seeing and frankly, this is something you guys challenged me on, was to do full arch digital scanning all the time. For years I did more quadrant scanning, more half the mouth scanning, because I was in the mode of like maybe triple tray. I was like, okay, well, I was giving you triple tray impressions. So for like a single unit, which was working great. So I was doing a triple tray, if you will, scan for single units. And then as we started, you guys were like, I really need full arch because I can eliminate a lot of problems if you give me full arch. Well, then I was scanning still just one side. And then as I started looking sometimes at the opposite side, you're like, whoa, that is totally jacked. Like that is not, like you say, there's these collisions going on. And what is surprising to me is that this, whatever you want to call it, this software that does not know that, does not see that data sets should not be overlapping each other the way that they do. It should error out. And I'm surprised that it doesn't. So I guess that's what I'm seeing as I'm going, I don't think, Wes, that, and this is for me at least, I wasn't looking at it as much because I was just going, okay, it registered. But as I started reading some of these studies and seeing that they were having these issues, I went, okay, I'll start looking more at the contralateral side. And I was surprised at how sometimes I was seeing these wacky collisions or open bites on the opposite side. And then sometimes it was understandable. Like you say, the patient has an open bite. Software doesn't know what to do with that. But even with normal occlusion, it's like, I just think it was the limited amount of data that we were getting, or like the patient moves. But what in the world, like the software doesn't know that that's wrong. I understand it being open, but being overlapping, colliding, I guess that's where another software comes in, which is kind of crazy to me, but I guess that's what they have to do.
Yeah. And John, you just said the magic potion. That why did we do triple trays a long time ago? Really, I think it was time saving, cost savings, right? The magic potion to digital right now is to completely get that out of your mind, because you're not cost saving. You have the digital scanner. There's no material to save anymore. The only thing it's costing you is about another minute to a minute and a half of scanning time to scan full arch upper, full arch lower. What that gives the laboratory the ability to do in 3Shape and exocad, we have virtual articulators, virtual jaw motion. So it'll go protrusive, right, left, lateral. We could clear out cuss tips, basically clear out any lateral interferences virtually. And that's what we're all headed for. I mean, we're the fast push to, do I need a model anymore? Do we, and a lot have done that in the past. It just completely went modelless. We haven't yet, because there's still, I think, some caveats that we can give a better product with a model to touch, contacts and occlusion. I'm sorry, contacts and margins. But occlusally, we're really developing most of our occlusion digitally now, but we can't do it with a triple tray or a quadrant scan.
Brad, are you saying that from here forward, for the best thing, the best data, the best whatever you're trying to achieve from a single unit perspective, we should be capturing more than the quadrant?
100%. I'm not just saying it. Be honest with you, we're almost starting to demand it as a laboratory. I mean, our customers are looking for crowns that seat in 5 minutes. They want to have occlusal contact. They want to have good contacts, adjacent contacts,
but Brad,
and good
I'm
margins.
not having any problems.
You gotta have digital.
But I'm not having any problems, Brad. I can just hear people right now listening to this show.
But
I'm not having any problems, Brad.
Sure.
Not this time. Not the next time, but maybe the time after that. But after you've done a couple of them in a row, you kind of get bias, confirmation bias. Oh, it's fine. Well, I had to adjust one. Well, why do you want to adjust one? You want to adjust none.
It's not repeatable.
Well, and two, I think you guys are, you mentioned earlier, like the labor shortage issue. When you're also, there's a training aspect to this, that if you're training a technician, I can imagine that, you might be able to do more with a quadrant and a digital model, say, Brad, than what somebody who's been doing this less than a year can figure out. There's certain things that if you're experienced, that you can cut through some of that and maybe do more with a triple tray, if you will. but your newer technician, giving them more, more information. I think that we all have to realize that's kind of who we're dealing with more and more and more these days. We're trying to simplify this. And that's, again, kind of like, we can't always have Brad or Derek work on every case. We can't.
Right.
And so you've got to have the more data. And like you said, it messed with me when I thought about that, because it doesn't cost us almost anything to give that data to the laboratory. It's very quick. It's so easy to do that.
Yeah.
So in fact, one of the things that we did probably in the past year or so, I had this conversation about full arch scanning with Brad regarding implant impressions or implant scanning, let's say that. And he said, Wes, I just want you to go full arch. He was like, it takes you no time. Just do it. And I looked at my head assistant and I said, hey, full arch scanning every single implant case. And she was like, no problem. Takes no time. That was her exact words. Takes no time. And
the scanners are so much better.
Yeah,
they're so much better than they used to be. Now, a couple of years ago, maybe that's a time consuming, but they're all so fast now.
Yeah,
they're
all so good. And one thing too that you might think about, there's ways that you can have your assistant scan up to the working site, right, preoperatively before you get into the room, and then what's left is to just stitch that last little piece of the quadrant together. So you're, as the doctor, you're lending over some of the scanning to the chairside assistants. It's a great way. We do it in our office, and I think this is great. What do you think? What do you think, John? Is it now that the days of when Wes Mullins was taking full arch improgram impressions for single unit restorations, Brad, back in the day, single unit restorations, full arch improgram for the first 4 years of my practice, trimming my own dies, we're back to the same thing. Old school really influences new school. Right? Now, Derek, you're new school. And there's some new school stuff right now that is
Absolutely.
like so exciting. And years ago, Brad and I sat down and we were using just digital photography and some little strange glasses, to just be able to have some kind of measurement technique to measure the length of 8 and 9 and put faces to teeth, and trying to use Smile Design software. And man, I just kind of gave up on all that, Derek. And I said, I'm just going back to Spear Education PowerPoints. And that's what I've been doing, because it takes forever to do a Smile Design workup on a 2D image. Is 2D imaging over, Derek? I mean, or do we need to pay attention to the guy on your left and say, whoop? Is that what Brad's saying to you, Derek? Is he saying, go digital, like let's do this new stuff? Or do we need to come back and respect some of the old school stuff? Derek, I want to hear from you on this.
I totally see the benefit of 2D imaging in Smile Creators and Smile Designs and Smile this, not the PowerPoints. So you can throw these 2D images up right over top of your designs and have everything ready to go right there. So it might seem old to take these photos, these 2D images, these 2D things, but everybody's got a cell phone in their pocket that can take an amazing picture and at least start piecing together these little bits for the lab to see what's going on. Like, it's cool to have an upper and a lower arch digitally scanned, but we need to see the face. Okay, cool. Take some nice, good quality photos that we can utilize when we're placing that tooth inside of that person's face, placing that in front of them. So it's almost as if they're sitting in the chair with us. And then the next thing might be placing a 3D person in front of us, actually sitting them down in the chair or virtually on the screen in front of us with a 3D image scan, taking those little steps forward from 2D to 3D, getting us more data. It's the same thing as, okay, a 2D image is a quadrant arch. It got us where we are today, but you might as well scan the full arch. Well, why take a 2D image when you can take a 3D image and get us more data, more information? Gives you a better product in the end.
If you looked at it, or the olden days, Wes, you said it. We used to have special software. Remember that? And you said the glasses.
Yeah.
The problem is we took a 2D picture and we would superimpose 2D teeth on a 2D picture. And what that gave us was, okay, the length of the central will be 11 and the width would be 7.5. But how do you take that 2-dimensional and transfer that over to reality to the patient in a 3D situation. Years ago, that wasn't possible. And it's kind of frustrating because you would show the picture to the patient and say, Miss Jones, I can make you look just like that. But then you'd prep the patient, you'd send us a model, which is 3D to us, and we could not replicate that 2D image back to three-dimensional. So you seat the case on the patient and they go, Dr. Mullins, that doesn't look like what you promised me. You promised me I'd look like that. I don't look like that. That was the gap. So what Derek's talking about now, and the changer is, you can three-dimensionally scan intraorally teeth, upper, lower, bite registration. That gives me a three-dimensional file of the patient's teeth. Now add a two-dimensional photo. From the top of their head to their chin is the photo I'm looking for. 3 different photos. One, full retraction. So retractor is in, having the patient bite down, looking straight ahead. That's the first picture. Second one, retractor is out. High smile. Shows me how high the mobility of the upper lip goes. Third, reposed. Lick the lips, say Emma, and hold. Lips apart. I want to see if the patient shows any of their centrals with their upper lip at rest position. That's why they have to be lips apart. Those 3 pictures we superimpose into our software now with the 3-dimensional scan of their teeth. We merge that into a smile creator, a smile design. And now we can send the doctor an HTML file to show the patient what they would look like. And we can actually take that and replicate it. When you prep the patient, we can actually merge our original design in with the preps to give you the exact same shape of teeth that we said we could do, as long as the doctor does proper reduction, of course. But that is what Derek's talking about, is how it's a kind of a game changer, how we're getting the patient in front of the technician, 2-dimensionally merged with a 3-dimensional intraoral file. So that's one level. And now, Derek, what's kind of the new thing that we've been messing with that's more of a 3-dimension versus 3-dimension?
Yeah, face scanning. What's better than 2 is 3. So
now, before we get into face
sit 'em
scanning,
down.
just real quick, just to say, if you have, because the now market share penetration of intraoral scanners is as high as it is, and a lot of people have at least some basic way of obtaining a 2-dimensional image, like you mentioned, for a lot of clinicians, this is very achievable now. And that's something to really pause on and just kind of go, okay, if you're not, like, let's just kind of talk about who's listening to this. If you are in a situation where you've struggled with this, of how to give a patient, or really, and I still struggle, and this is maybe my own thing, I still struggle with showing this to the patient, to be honest. I struggle with it because I go back and forth, and if you talk to Greg Kinzer, he would say, don't do it. Don't show the patient some idea of what because how many times is this literally just doing the veneers? Many times it's crown lengthening, it's gingivectomies, it's orthodontics. There's so many things in many of these cases that are the very complex cases. But be that as it may, regardless, you can get an idea for yourself, for the lab, for the specialist you're working with, for the orthodontist, and yes, even for the patient, of what could be possible just with technology that now most of us have in our office. And I think important too to mention that if your lab is not asking for that, you may want to start asking some questions. Well, if you heard this on the Dental Guys today, that this is possible to be able to create essentially a preview for the patient and you and the specialist, whatever, where we used to just do PowerPoint overlays. Now we should maybe be asking some questions to our laboratories as to what's this all about. And I will say, guys, who's paying for this? Is a good question I want to maybe ask you guys, because obviously it helps you tremendously. So there's a benefit to you doing these types of setups and communicating about what's going on. But how do you guys handle that? Like, there's a tremendous amount of technology work involved. Is a doctor paying the same thing as they would just for like diagnostic models? Is there like a design fee? How does that work for you guys? And Because I think people start to think, okay, if people are doing this, they want people to do this, but like, how does that work in the workflow? If you want to have like Invisalign, right? It's called a CLIN check, right? We send all this stuff in. They show us what's possible. It costs us, quote, $0, right? Except for our whatever we bought to take the information. How are you guys handling that? How do you look at that from a diagnostic standpoint? Or is that always part of the case that you're kind of, charging for?
So let's just talk through. Let's say you have a patient that comes in there. You're going to do either veneers or crowns 6 through 11. We'll do a smile design, which would include, you need to send the 3-dimensional intraoral scans, upper, lower, and bite, the 3 pictures I just mentioned, and we do a smile creator protocol. And it's like an $80 fee to the doctor. And it's an HTML file. They can fade in and out, show where the teeth were, fade the new teeth in. It is 3-dimensional on the teeth side, but only 2-dimensional on the picture side. So it's $80, a lot cheaper than sending to the lab for a diagnostic wax up and then, having the patient say no. So it's kind of it's the tool to show your patient for them to say yes, right? And
That's
we're showing
huge.
higher acceptance. It's huge. So now patient says, John, love you. Make me look just like that. Now you can call the lab and say, hey, I want a diagnostic wax up. Well, I already did it. It's done. Because I did it because you gave me the 3-dimensional image of the patient's teeth. So all I need to do is print a model. I already did the design. Now I print a model. And in our lab, what we do is we charge for that printed model, but we never just send a printed model. We do a Siltec or a putty temporary matrix to make the temporaries in the mouth. We also do cutback jigs too. So they're cutback jigs. So you use them intraorally to make sure you give us enough reduction to give you the product that we said we can give you. And we package that together. It's there. We don't cut one or the other out, whether you use them or not. We want the doctors to use them so we have the right reduction. So there's a separate fee that you get the model, the reduction guides, and the matrix. That's the next level. Okay. And there is a fee for that, but it's less expensive than what we used to charge when we individually waxed up teeth in hopes that the patient would accept it. And it still puts you back. And now the cool part is, John, you prep the teeth and you send me a new scan back in. We take that new scan and we merge it back into the original design. It's not a new design. It's the same design. And we basically snap the margins to the original design. And we're able to recreate what we created on the first design. So look at the efficiencies in the laboratory. We're not designing multiple things. We're designing one thing and then merging it back in. So it's more efficient for us. And we're able to give you the same product we showed you from the first preliminary design. Does that make sense?
That's powerful. I mean, it's powerful. So if you have this information, right, that we just talked about, everybody should want this, is the way I look at that. Everybody should want this. It's a no-brainer. It's giving somebody the potential for a reality check of what the lab can actually do. So what's the next step? You mentioned 3-dimensional facial scanning. So talk about that. What does that add to this equation as we're starting to kind of build toward this virtual patient? What can you guys do with that you maybe can't do with just a 2-dimensional photo?
So we brought up that we need the 3 photos that are all straight on from that patient, looking right down the nose, no turning of their head because things look a little funny then. We're looking for that straight. Well, not everybody looks at everybody straight on. Sometimes you're talking to people from the side or from an angle, or rarely ever straight on ahead. If you take a 3-dimensional scan of somebody, you can see, oh, look at that, they're overjets, extreme, something that you might not be able to see when you're looking straight on. Well, when we're designing our, virtual teeth setup inside of right before you would, get your patient acceptance, we can go, oh, let's fix this overjet. Let's bring this back a little bit. Here's how your lip's going to fall now. Or maybe you need a little bit more lip support. Here's how we're going to move these teeth. That's something you just can't get with 2D images.
So it's a side profile. It really, because 2-dimensional, if I have a flat picture in front of me and the minute I turn 3-dimensionally sideways, you can't see anything because it's, the picture's flat. So now if you give me a 3-dimensional image, I have you now put the patient in front of me.
So that's
Literally.
exactly right, Brad. This is the key. because we've talked about this for years. Not everybody can have the lab technician chairside during the temp preps and setting the patient up and bringing in and doing all the ceramic trying and bisque. And if you don't know what that is, look it up. But I mean, you can't. You can't afford to do that. Not every dentist can afford to do that. We all can't have a laboratory setting in the room next to us with somebody that's been doing it for 30, 40 years and then have the ability to spend the money on research behind this. And like our dream is to bring laboratory technicians to the chair. Because the biggest problems, John, you and I see are not necessarily with, well, 8 and 9. It's when we start to turn the corner around the arch. We start to see teeth that are protruding or lingualized. I mean, it is a real problem. And contouring, right? Because if you're training a new technician, Brad, and they've never been next to a patient, what's the best way you can help them with their contouring and all that, right?
Bring the patient. We just had that happen the other day, guys. We had a patient that wanted 6 through 11. It was an old bridge, and they wanted 6 through 11. So they sent in the photos with the 3-dimensional intraoral scans. We imported everything, and we redesigned her teeth, brought the overjet back. We shortened the teeth. They're a little long. She showed it to the patient. She called us right away, and she said, can you guys add the bicuspid? She wants to go back to her second bi because now she noticed that she shows teeth back further in that smile you sent. So we added 4 more teeth, sent her the new design, and the patient's like, yeah, that's what I want to look like.
Yep.
And done.
Because they can see it where they couldn't. But I think the other side to that is I just remember a huge failure that I had one time years ago on a hybrid immediate load temporary that was pre-made from the lab.
Wow.
And this was because we took a straight on photo, and the patient, you know, when a patient has their, you know, video collapse because of perio, and you see this flaring forward, this like the maxillary 6 start to flare, and it's because, you know, they're losing support, the tongue's pushing forward. So, you know, if you send that to the laboratory and all you send is 2-dimensional information on the design, and yeah, they have a model, but they don't really know exactly where the lip is. They don't see it from the lateral. And you know, they create this, they basically took, you know, where mine says les position, and they put teeth right there, and they kind of uprighted everything. So we had this tremendous excessive lip support on the provisional because you couldn't see it from really the lateral view. You couldn't scroll around and see all dimensions. And I've seen now with these cases we've been doing using 3D scanning, facial scanning, and the difference that you see in just the ability to predict how the lip's going to fall, Derek, like you said, like now the lip's going to fall in a different, and there's data research actually, which we can't get into too much tonight, but there's research to show if you add this much contour to a tooth, here's how much the lip is going to come up above, and here's how much it might drop down. Very similar to like working tissue with an implant provisional. When we add to the subcritical contour, we know how much that tissue is going to go apically. So for the sake of time, because we could talk about that for all night, what is the next step? I just want to touch on a little bit because I feel like it could be a whole, you know, discussion in of itself. You know, the one missing piece that people have been trying to, for years, to crack the code on with all of this virtual patient has been the implant patient with multiple implants, right? We take all this information we're talking about, or even if we don't have all that information, there's always been this challenge of trying to do digital on a full arch implant patient, right? Trying to get implant positions digital without the use of impressioning and verification jigs and all the steps we go to. So this new technology comes on very strong in the last couple of years called photogrammetry. Talk to us a little bit about what photogrammetry is, what it's the technology's about, and then a little bit about how you're starting to use this in the creation of the virtual patient when it comes to full arch or even partially edentulous implant patients.
Go ahead, Derek. This is one Derek has dove in pretty head first.
I could tell he took a deep breath. He was like, yes, yes.
Yeah, can I have the mic,
Yeah,
please?
I'll start out with like intraoral scanners, how those work to piece everything together. You see how many times if you have an intraoral scanner, you start in one spot and it takes a picture, and you move a little bit and it takes a picture, and you move a little bit, it takes a picture. And a lot of them have the counter of how many photos they've taken. You might be, 1,000 photos by the time you're done if you really can't get anything. And you're taking all these little tiny pictures and stitching them together. Over time, you end up with a tiny bit of error. It might be like maybe a micron, but you add a micron error, a micron error, a micron error. You're all the way across that arch. You got 1,000 of those microns added up. You got a millimeter off. Where's that? Yeah, millimeter off. Well, you want your arch fitting about a millimeter off. It's never going to fit down right. You're not going to have it right. A photogrammetry camera are usually held way back from the patient. You're stepping back a couple of feet and making sure that they have retractors in their mouth, and it's looking at everything. You're putting these special hand-calibrated scan bodies that are only made for these cameras in at one time, and you're able to see every single point in one photo. You move it slightly off to the side and you're taking a picture from there, and you're seeing everything in one photo. And just like how GPS would triangulate your phone from space, it's seeing the entire Earth, the entire network, and pinpointing down to a couple feet. It's exactly what this is doing. You're stepping back a couple feet and you're seeing the entire scan body site, all the implants in one go. You're going down to the micron level of accuracy across your arch. The only thing they're doing is capturing single site locations relative to each other. That's
John,
all that
this
their
is
goal
this is the thing that we've been keeping impression material for years. We've been keeping it for cross arch accuracy. We know that Improgum was the gold standard for years and still is for cross arch accuracy. We know that verified impressions, right? Actually taking impressions of splinting like bars together, right? Easy bar, right? Brad, we loop bars together in the mouth and then take an impression of the bar, 6.5 minute set time, right? Because we have so much to go for here. This is it. You're taking it. You won't want to mess up, and you then verify it again.
Yeah, and we still have to section half the jigs.
It's crazy.
Because
Duralay pattern resin, which one to use? That's a pain in the butt. What you're saying, Derek, we've read the literature. It is proving out to show that photogrammetry is winning. And
if it fits,
it works.
It works.
It gives you the passive fit you're looking for, because Derek basically said intraoral on average 320 micron deviation from right to left. Photogrammetry average 5 micron deviation.
Whoa.
Whoa. So that's,
and if you look at these
passive fit.
And if you haven't seen these before, there's several brands, right? And there's several brands, and in fact, even small companies are coming out with these. But some of those out there like Instarisa, Micron Mapper, even Blue Sky Bio has one. I mean, there's a huge range of these, and different advantages, disadvantages. And I don't want to dive too deep into that today, but just to say, go check some of these out. Essentially, what it looks like is a little. The way I've explained it to people is like a little QR code on a coping. It looks like either a little domino, like those that Wes is showing if you're watching the video now, or a little kind of a QR code looking thing that fits on top of your multi-unit abutment in most cases. So you're able to see, everything about an implant, depth, angle, and most importantly, it's the relative position, right, of each implant to each other is really what photogrammetry is giving us, the position of each implant to each other. And then you guys are able to go back and merge that information in with everything else. And so walk us through just quickly in the 1 minute version of what becomes possible for full arch implant immediate load dentistry. What can now be done if we employ all of these technologies? I know it can't be 1 minute. Give us the 1 to 2 minute version of if you have the data that you need pre-op, and what does that kind of look like? What are we doing the day of surgery, and what are we able to do from a provisional standpoint. And then we'll talk maybe to finish the show about what this changes about the final restoration as well. But kind of talk us through what could this do? Not could it do, what does it do
Yeah, because
for
it's
these
doing
people?
it. Yeah, we're
Oh,
doing
yeah, it's
it.
doing it.
And,
We've done
and
it. Yeah.
We've done it,
Yeah.
and we're doing more of it. So
Yep.
if you're listening to this, yeah, get ready because it's coming. And Brad, you're on the train already.
And this is nothing that, I mean, this isn't new and not proven. This is proven. And like you said, Wes, there's plenty of research articles out there to back up the accuracy of photogrammetry. The hardest part is technique, isn't it, Derek?
Absolutely.
Kind of what we talked about earlier. It's the doctors have to provide us the information that we need. So, pre-op, Derek, why don't you know that the case walks in and it depends on how they present themselves. Every scenario is different. But if we have, let's say, an edentulous patient that shows up and they want to get implants and they want to get an implant retained prosthetic, take that scenario, Derek. What do you need for information from a preliminary side?
So we need to know everything starts with vertical opening. Where are they at? Do they need to be opened? If they're dentulous, they probably have a denture. Maybe the denture is destroyed. You got to open it up. Start there. You have to start. Vertical opening is the most important part.
So make a new denture and get that perfect. Get the teeth where you want it and make sure the vertical opening is exactly where you want it.
Exactly. Because if you don't have your vertical, you're never going to end up right. Yeah, exactly. Diagnostic setup, get it where you need it to be or it won't end up there. Start first with the easy part.
And most of those now we're doing digital. So we're not doing the old T-set and wax. If they have an old denture and it's a starting point. And even though they don't have like the vertical, they can take that denture and take a reline impression inside of that denture, take it out of the mouth and scan that denture. That gave me a digital impression, and put it back in the mouth and determine the vertical. You could use a Lucid-Jig. You could use a leaf gauge to open that vertical chair side. They could scan the lower arch and then scan the new vertical using the leaf gauge to open that vertical up. That gives me the bite at that new opening. And we digitally design a try-in denture and send it out for try-in to make sure that the tooth position looks good and the vertical's good. It's just try-in. You're just getting it where we want it. Does that give us the information then, Derek, or where we need to start for photogrammetry?
Yeah, you might have everything set up and ready to go, and your teeth might be already in the position that you want, ready to go for implants. You can start scanning that new denture and your new vertical, and then you're ready to go to surgery almost. It depends on how you want to set stuff up. Maybe you're sending out for a surgical guide. Maybe you're doing this immediate load. You take those scans, you can get everything set up for that, and you start capturing.
In this case, if it's a freehand case, you can take that same denture. We can cut a window out to put them, use it as a reference of kind of keep the coronal part of the implant in this location. Then they can look at their CT scan for where they want to put the apex of the implant. If they want to have a guide, now we have a denture, and we can do a surgical guide based off of that to have surgery done. That in that case, that puts them to surgery, and we haven't taken an impression yet. The doctor did a reline impression in the patient's mouth, but we never sent anything anywhere. It's all been digital at this point in time. So now we get a surgical guide. You place your implants. You put your MUA, multi-unit abutments, on. And most of these cameras, most of them are what we call the Nobel compatible type MUA abutments. And now we're at a stage where we can scan the implants with the micron mapper, the special dice you throw on, and you get the micron mapper that gives us exact location of the implants. Those come off, you put tissue caps on, and then you can suture up, and then you grab a scan of the tissue after it's sutured, so we understand where the tissue is at surgery. All those files get uploaded to us. We merge it back with a preliminary design of the denture, merge it back with the micron mapper. We know where the implant location is, and we're printing out a direct to MUA temporary that day, either chairside, or we'll develop a file and we'll send to the doctors who have their own printers. We'll just do the merging and the file design, and the doctors can print chairside with their own printers that they might have.
So you hear all this, and it sounds a little overwhelming. But honestly, once you've done a few of these, it's not the actual process, and the technology part is not overwhelming. It's not. The part that is not overwhelming but is important to realize is that there's still a lot of thinking involved in the planning process in even the day of surgery, depending on kind of how things go. There's certain things that you need to be thinking about. You can't be mindless about this, but because it is still garbage in, garbage out, right? As we know. But there's so many powerful things that I've seen as we've done some of these cases. One of the most powerful things being no longer do we have to have guides for some of these cases because, right, the guide, we used to do these pre-made temporaries, still based on a lot of pre-design, but we used to do it based upon, hey, the implant needs to go here so I can pre-drill my holes. We can, pick up the provisional based upon, well, what if something didn't torque in?
Because
what if
it
something
always
wasn't
does,
stable?
and then like the stupid temporaries trashed because we have to
That's
cut
right.
it out, and then it
Yeah.
breaks 3 months down the road, and you're not ready to load the
Right.
final. It happens all the time, and people
So
think,
now-
"Oh, this is Dreamtown," right? I think
That's right.
it's not.
So now you take that, you go, you know what? Actually, I just don't like the bone there. I'm going to put an implant in number 4 instead of number 5.
Happens all
Because
the time.
it doesn't matter to the photogrammetry process, because in the
Nope.
end, all the technician needs to see is where are the final implant positions that we like. So as long as we have a surgeon that's either, guided in some way or talented enough to know where things need to go restoratively and places implants properly, then we can, which is a big if, I know that, but it's still something that we can on the fly do the design process much more easily. But I think that just for the sake of time, I mean, we probably need to have a whole other episode on this because we want to talk about cases and talk about specifics. But as a restorative doctor, honestly, all the things you've just said, including the fact a mechanical engineer said lip support, I think it's a first for all mechanical
I know where
engineers.
you're going, John. I
But-
know where you're going with this.
But I think the most powerful thing as a restorative dentist is I want to walk you through this. And listeners, I know that probably 93% of people listening to this have never done a photogrammetry case, probably 99%, and that's fine. That's fine. But think of this. Think of all the steps. Once a traditional case heals, right? Traditional case, we do immediate loading like we've always done. We select our multi-units. We take a denture. We do a conversion prosthesis, whether it's pre-made, guided, or fancy, or whether it's just a denture, we convert. Okay, so we go through 3 or 4 months of healing, whatever it is you choose. Now I want you to just briefly think of all the steps you go through to create the final prosthetic. We have a preliminary impression, potentially. We have a custom tray impression. We may have to change multi-unit angles or depths or sizes or shapes. And we finally get that. We get a verification jig back. We might have to section it. We might have a new impression. Maybe not. Maybe we get lucky and we get everything right. Then we do a wax rim maybe, and then we come back with aesthetic try-in maybe once or twice. And then we might have a bar try-in, or maybe we don't. Or maybe we have, a PMMA, maybe a second PMMA. And then finally, we're ready to take that PMMA off and either send it back to the lab or scan it on the model, right? That's the overview. Now, imagine with photogrammetry. If we do a good job on the design from the beginning and we have our vertical correct from the beginning, we get all the data at the beginning and we get the photogrammetry done and we print a prosthesis that's based on the design we designed before we even saw the patient that day. And we get, say, 95% of the way there with the provisional, which I can tell you we do because we've been doing these cases. Now, the patient heals for 3 or 4 months. You know how many appointments we now have? We now unscrew the provisional. We take a scan of the healed tissue. We then put the provisional back on. We send that to the lab. And, the only thing the lab really has to care about is where's the tissue now? Where's the tissue now? And are there any changes that we want to make to the design? So we'll probably make a second PMMA just to be sure that any final occlusal adjustments were reflected properly, or if they want to change a little bit about, pointier canines, a little different shade, whatever. And then we can trial run that if we need, or maybe not. There's no more of all of those 6 to 7 appointments that it takes us to go through this process. And if you let that sink in for just a moment as to what that means in your practice, if you're doing these full arch implant restorations, I mean, it's absolutely will blow your mind apart. You're like, are you kidding me? You saying all I got to do is scan the tissue and then maybe make them another PMMA? This is so powerful that I don't even think our industry has grasped yet what this is going to mean for our whole world of doing these immediate load prosthesis, I mean, I don't even know what's going to happen to costs. I don't know what's going to happen to availability. I don't know what's going to happen to populations that could usually used to not be able to even afford this. I mean, what do you think, guys? What do you think as we kind of close out the show? What is this going to do to full arch implant dentistry? If you could kind of give us your kind of quick take on what does this change?
I'm just going to go after the cost side of things. You hit it, John. Some of this is not attainable by a large amount of the population just due to cost. From our side in the laboratory, it has minimized our costs because we have less steps. We're not making multiple base plates and bite rooms, multiple PMMAs, verification jigs, models, analogs, cylinders. All of that stuff was cost to us. So it was driving the lab fees up. Therefore, the doctor was driving their fees up because you guys got to cover your overhead, got to make a profit. I think that you're going to find that it's going to be more economical all the way across the board, and that gets passed along to the patient. And we're going to do a lot more of these. We're going to do a lot. We're already seeing it.
Mm-hmm.
I mean, we started turning this on, and I mean, there isn't, I think, 4 today.
Yep.
that I treatment planned in one day with photogrammetry. So I think your volume is going to increase due to accessibility to the patient base. And I'm pretty excited about that.
I'm excited. I'm also concerned because there's only one correct diagnosis and there's many ways to treatment, as Dennis Tarnow has said, John. And what I get concerned about is that we don't take the proper steps and the proper training. What we elegantly described, and Derek, the mechanical lab guy here, described was the steps of dentures. And we've talked about veneers are dentures, and dentures are veneers, and full arch cases are about where 8 and 9 goes. And Brad said leaf gauge and all those things. And what I would say is that my concern is that dentists don't get the proper training in restorative dentistry, understanding people's diseases, right? And I am concerned a little bit about that, and I'm excited to help people find a better way to understand these things. That's why John and I exist, is so that we can help each other. And that's why Brad and I, and now Derek and John and ourselves, the 4 of us, have a relationship together, and it's been strong for so many years. Before the dental guys even existed, we were having these discussions on napkins. And we are better because we're together. And so you need a partner when it comes to these type of things, because there are so many people who are going to want this, and you're going to need someone to help you along the way. And that's why Brad, the dental lab guy, and Derek, the dental mechanical lab guy. I don't know what we're going to call you, Derek.
Good enough. That works. Just keep going, adding more terms.
Yeah, we're going to just keep adding until one sticks. But what I'm saying is that you've got to have partners in this. Don't fall into the trap of blaming the lab. Partner with the lab.
Well, and I think the days of for so long, Wes, and we talked about this on the show multiple times, the guy that would be, or girl who would say, hey, I'm doing this all in-house. I'm going to do everything from the design to the implant placement to the restorative to the printing, all this. With this technology and everything we now know, I'm not saying it's impossible, but I think you start to see that it's incredibly difficult to go this on your own.
Yeah.
You really need I mean, they've got 2 freaking mechanical engineers at this lab, and they're figuring stuff out. So, we can't have this idea of like, well, we can figure, there's certain things that we're really good at and we need to do what we're good at, but we also need to delegate what someone's better at. And I think that that's what we're figuring out. The better the technology gets, the more pieces of technology that we might need to invest in. We have to figure out what makes sense. And I think that having somebody in your corner that gets it and is doing the actual basic research and vetting this process out and can say, yeah, we've done 1,000 or 100 or 50 cases, whatever, that's who you need on your team. Because I think the days of this being done in-house are just going away more and more and more. You think it would be less and less, but I think it's going away more because we're getting more complicated. At the same time, we're eliminating a tremendous amount of steps.
Brad,
So
I'm going
I
to give you
think
the
that
last
it's
word here
good.
tonight before we close out the show. And Brad, tell us what you're most excited about. We're going to have Brad back on the Dental Guys later this year. You know, you guys love the Brad, the Dental Lab guy, and what he brings to the table, the knowledge he brings. Brad, last word before we go. What are you excited about in the coming months?
In the coming months, it's an all-on digital workflow. Push it. We're going to push the limit and go as far as we can with digital. It minimizes everybody's overhead. It increases efficiencies. It can increase accuracies if it's done properly. And I think we're gonna push forward really fast. Did you agree, Derek?
Absolutely. Yeah. That theme of making sure things are collected properly doesn't change between analog and digital. So do it right digitally, and it'll make it even better and faster for you, for everyone.
Do it right digitally. Merge analog with digital. New versus old. John, I'm pumped.
Man,
I'm excited.
I know.
Right?
I know.
Thank you,
If
Brad.
you haven't
Thank you,
already,
Derek. So
yeah,
much.
if
So
you
much
haven't
fun.
already,
Guys.
check them out at dentalcrafters.net. Obviously, we know they're doing it right. And if you haven't already, like, share, and subscribe to the Dental Guys. And remember, text us if you have comments or questions or want to hear more about these technologies. We're going to try to give you as much as we can in the coming months. We're trying to cram it all in. Thanks once again for being with us on your lawnmower, in your car, on your drive to work. We love having these conversations with you. We love the support you give us. Thanks for everything you guys do for us. And for Wes, I'm John, and we are the Dental Guys.